So the nice thing about treating patients with autoimmune disease is they usually come in with a lot of problems, right? So like patients don't just come in with like rheumatoid arthritis or psoriasis. They usually come in with rheumatoid arthritis, a little bit of hypertension. Usually a lot of times they're overweight. Sometimes they're insulin resistant. Sometimes they have food allergies too. So it's like have to treat everything, and that's part of the reason why I like these patients. So we're going to focus on autoimmunity. We looked at the functional medicine matrix yesterday. Obviously, we have a big task. And as I just said, we have to remember and apply what we've already reviewed about cardiometabolic syndrome and allergy as well. A lot of these patients with autoimmune disease have higher incidences of obesity and diabetes. And that can be because of the lifestyle that helped generate their illness, or it can be because of the medications that they're taking. You know, one of the most commonly used medications for autoimmune conditions is steroids, prednisone. It makes people insulin resistant, it makes them hypertensive, so we have to manage that while we're treating the rest of their condition as well. These patients with autoimmune conditions always have a heightened risk for developing cardiovascular disease because of the systemic inflammation, as you would expect. And they also have higher risk for developing kidney damage, which we'll review again today. I know we talked about it yesterday. Autoimmune diseases, again, we looked at this yesterday. One of the major leading causes of death in the industrialized world, surpassed only by cancer, heart disease, and adverse medical effects. So part of the conversation that we have to get into now, because we're talking about autoimmune conditions, we're not just talking about somebody with a runny nose and a little bit of eczema. Most of the autoimmune conditions should be considered to be at least potentially life-threatening conditions, or limb-threatening conditions in some cases. Sometimes patients with autoimmune disease, like I had a patient a couple years ago with rheumatoid arthritis, and she, on the first day I saw her, her chief complaint was rheumatoid arthritis. But the urgency that we had to deal with the first day I saw her was she had developed what's called transverse myelitis. So this is about a 25, 28-year-old girl who had developed rheumatoid arthritis about a year after she had given herself breast implants. And the first day I saw her, she was in the waiting room, so I went in to greet her and walk her back to the office. And I noticed as she was walking, she was just kind of like shuffling her gait. And I have to kind of stay in front of the camera. But anyway, she was just kind of like walking like this, almost kind of like a Parkinson's gait, right? Kind of a shuffling gait. And I was like looking at her and I was thinking, it's going to be one of those days. So we went back and we started talking, and I said, you know, usually I do history and then physical exam. We talk about treatment plan, but I said, I'm real concerned about what's going on with your lower extremities. So we went right into physical exam, basically. So she sits up on the table, and I test her Achilles and patellar reflexes, and what do I find? She's hyperreflexia with clonus, right? So we're in the danger zone already. Of course, as I recall, this was a Friday afternoon, which is usually when all hell breaks loose, right? So she's got shuffling gait, she's got spastic weakness, and she's got hyperreflexia with clonus. So what's the DDX? The big DDX here is spinal cord compression or some type of spinal cord lesion, or at least central nervous system lesion, whether it's spinal cord or brain. But in her case, I thought it was cord. So I called her, I think he was actually an orthopedist, even though she should have been under the care of a rheumatologist. Anyway, I called the doctor she had been seeing, and I said, you know, I'm real concerned this patient's got transverse myelitis. And he said, well, she can't have that. I'm just telling you the truth. I'm not making this up. He said, well, she can't have that because I already did an MRI of her lumbar spine and it was fine. Right? So I'm thinking to myself, stay calm. There's no cord in the lumbar spine, but we're going to work through this. And so we had her go in for a contrast-enhanced MRI, and she had transverse myelitis, so she had to get treated with steroids. Anyway, my point is, something like that can happen with any of these autoimmune conditions, especially rheumatoid arthritis, especially lupus. So when you look at patients with lupus, you have to presume they are autoimmune all over the place, even if they just come to you with a skin rash and joint pain. So document the specifics of your plan and have some rationale for that. Don't tell your patients to discontinue their drugs unless you really want to take on a situation. Give patients written instructions, delineate the parameters and treatment duration for the next visit. So what I used to do with my treatment plans is, just like a prescription, my treatment plans would expire. And at the bottom of the page, my treatment plans would say, your treatment plan is good for the next 2 months only. After that, you either need to come back for a reevaluation, or if it's working for you, we need to modify it. If it's not working for you, we need to modify it. But that was my way of kind of covering myself, because inherent within that disclaimer, so to speak, was the fact that they have to come back and that this doesn't last forever, right? Because I don't want to see patients coming in for one visit, getting the protocol, and then taken off, and either, if they do great, that's nice, but a lot of times they'll crump, and then they'll come back, and they can actually sue you if you haven't delineated the time that they're supposed to return for their next visit, right? So your treatment plan has to include the duration of treatment and what they're supposed to do when that treatment expires, and the answer is always come back, right? But if you don't do that, and let's say it doesn't matter what the condition is, whether it's autoimmunity or cardiovascular disease or diabetes, if you don't specify the time that they have to come back, you're at risk for a lawsuit, because they can tell the court, well, I didn't know I was supposed to come back. It might be obvious to you, but it's not obvious to them. So always delineate the duration of the treatment. And the general rule that I follow, and most patients who, by the time they come to see me, they've already been treated by a couple of internists or rheumatologists. So I always try to keep the rheumatologist kind of on board, because, as I said, sometimes things crop up very quickly and you have to have the patient hospitalized or immune suppressed. Point number 6 here, practice defensively. It's certainly in your best interest as well as your patient's best interest. So how are these conditions treated in the medical world? We looked at this yesterday, so let's just review it again. ASA is acetylsalicylic acid. It's obviously aspirin. NSAIDs, and we could also say the COX-2 inhibitors, the COXIBs would also be here. APAP is the abbreviation for acetaminophen or Tylenol. After that, they go to prednisone. So what's the problem with using NSAIDs? And let's look at all those drugs. So let's just look at each drug. What's the problem with using aspirin? So it's a cyclooxygenase inhibitor. And it promotes gastric ulceration, right? Hospitalizes or kills about 17,000 people per year in the U.S. And all NSAIDs cause some degree of gastrointestinal irritation and therefore leaky gut, as we call it. What's the risk associated with using acetaminophen? It's conjugated with, in the phase 2 conjugation for acetaminophen is glutathione dependent. So it depletes the liver of glutathione. So people take it long enough, they get genetic damage and etc., as you would expect. What's the risk of using the so-called selective cyclooxygenase 2 inhibitors, the COXIBs? Well, the cyclooxygenase 2 isoenzyme is the isoenzyme that produces prostacyclin, which is an anti-inflammatory and anti-aggregatory prostaglandin, right? So when we use a COX-2 inhibitor like Celebrex, which is one of the only ones on the market now because the other ones were taken off due to their cardiovascular risk, we're blocking the body's internal production of a natural vasodilator and antithrombotic agent, right? So what would you expect to happen? Vasoconstriction and thrombosis. That's the perfect recipe for heart attack and stroke, and that's what happens with the COXIBs. That's why Vioxx was taken off the market, and that's why Bextra was taken off the market as well. Prednisone increases the risk for gastric ulceration. So a lot of times when patients are treated for autoimmune disease, of course they're going to get put on an acid-blocking drug like cimetidine or omeprazole. So we're just going to medicate these people into oblivion, basically, but that's how they're treated, so let's just talk about it. So prednisone increases the risk for gastric ulcers. So they're going to get put on an acid-blocking drug. We talked about those earlier today. So they're going to eventually have some degree of nutrient malabsorption, and they're going to be at higher risk for bacterial overgrowth of small bowel because of the antacid drug. Prednisone also suppresses immune function within the gut, so they're going to have reduced IgA. That's going to increase their tendency for bacterial overgrowth as well. Prednisone, as we just reviewed, also causes mitochondrial dysfunction. We already know it causes osteoporosis, so a bad situation is about to get worse. It also makes people insulin resistant and hypertensive. So, like I said before, if they weren't hypertensive, obese, and diabetic before they had the disease and the medications, then we can certainly make them so. Methotrexate's a folic acid antagonist, so to speak. It's used in the treatment of autoimmune disease the same reason it's used in cancer treatment, and that is because it's an anti-proliferative drug. So it just basically slows down the proliferation of lymphocytes, and again falls into the category of what I call immunoparalytic agents. It just paralyzes the immune system, so to speak, and that results in an anti-inflammatory effect, which is thought to be beneficial, even though, of course, we're not addressing the underlying problems, which we've already started to review. So methotrexate, usually patients just take it once a week, but what they should take every week, anytime they take methotrexate, is folic acid, usually 1 milligram per day. Taking folic acid with methotrexate helps to reduce the hepatotoxicity of methotrexate, and therefore allows patients to be on the drug for more consistent periods of time, etc. Sulfasalazine is another anti-inflammatory drug. It's probably the best one on the list. Sulfasalazine is not very well absorbed. It doesn't penetrate into the joints to produce its anti-inflammatory effect. It actually seems to function in the gut, and by alleviating gastrointestinal inflammation, that seems to be the mechanism of action of sulfasalazine in the treatment of autoimmune conditions. Well, that's the medical way of treating leaky gut, basically, right? Sulfasalazine, even though they don't know, most doctors probably don't know why it works, they just know that it works and it's FDA approved, therefore they just do it. But from our perspective, we have other ways of treating that gut, right? Hydroxychloroquine is an anti-malarial drug. Somehow it fell into favor among rheumatologists for the treatment of autoimmune conditions, and it's another good example of, again, what I call an immunoparalytic drug. It just kind of jams up the immune system, and that reduces the symptoms of these autoimmune conditions, but it certainly doesn't address the problem. Biologics, all of them, as I mentioned before, are tumor necrosis factor alpha blockers or inhibitors, whether they're antibodies or soluble receptors. They're usually administered by intravenous injection. Sometimes they cause allergic reaction. Sometimes they quit working after a while because the body will form antibodies against the biologic drug itself. They carry a pretty significantly increased risk for the patients developing infections and cancer, especially lymphoma, as I recall. And that's just because we're basically knocking out a major arm of the immune system. And that's the way medical therapy works. Stem cell transplant is also advocated for patients who have treatment-resistant autoimmune conditions. And that's going to be most patients, right? Because none of those drugs addresses the issues that actually cause autoimmunity, right? So, of course, patients are eventually going to become quote-unquote resistant to treatment because they're not being treated. They're just being symptom suppressed. At some point, these patients are usually diagnosed with fibromyalgia, especially now that anyone can be diagnosed with fibromyalgia. It used to be, you know, if you look at the 1990 criteria, the criteria mostly for fibromyalgia was body pain. According to the 2010 criteria, the sole requirement is that you have to have a body. And if you have a body, you can be diagnosed with fibromyalgia. So, the drugs that are used to treat this are pregabalin, which is basically a precursor to a GABA receptor agonist, basically. So it just alleviates pain. It's used for the treatment of neuropathy and so-called central sensitization. Also carries a black box warning. Duloxetine is another FDA-approved drug, and the other FDA-approved drug is milnacipran. Duloxetine and milnacipran are both kind of like SSRI, SNRI drugs, meaning that they potentiate serotonin and norepinephrine, so they're kind of antidepressant class drugs. Do they address any of the problems seen in patients with fibromyalgia? Not directly. They provide a little bit of symptom relief. With a black box warning for their increased risk for suicide. Pregabalin also increases the risk for weight gain. So sometimes people get on that drug and they gain like 30 pounds in 30 days. Any SSRI or SNRI can be justified in these patients because of course they're going to be depressed because they have a disease, they're not being treated effectively, they're told they're going to have it forever. Sometimes it leads to disfigurement or either of their joints or so-called disfigurement of their skin, kind of a cosmetic issue, which can be pretty significant. So it's easy to diagnose these patients with depression, and therefore it's easy to justify any of these drugs, whether we stamp them on the forehead with fibromyalgia or not. And then, of course, they're going to have pain, so we're going to treat them with opioids. According to the World Health Organization, there's a three-step protocol that's usually used. Again, it goes back to NSAIDs, aspirin, and acetaminophen, and then we add weak opioids like Vicodin or hydrocodone. And then after that, we can go to stronger opioids like a fentanyl patch, for example. And then after that, we can always add anticonvulsants to these patients who have chronic pain. So this is basically the medical management of autoimmunity, like rheumatoid arthritis. Typical patient with rheumatoid arthritis is going to live within this box for most of their medically treated lives, right? I'm not aware of anything beyond this. Do you want to add anything with your rheumatology training?
Some rheumatologists are starting to wean people, so they kind of get them they napalm it,
Yeah.
use your word initially, and then they try to taper the dose over time. We're stretching people out on an Embro to 10 days, 11 days between doses, and some people eventually can stop it, so they are going into remission at higher rates.
Yeah.
But now our doctors are doing it that way.
Sure. So mostly it falls within these parameters.
Yes.
You know, like when I first started medical school, first chance I got, which was probably the first month of school, I jumped in and did some observation with the rheumatologist because I had just published my integrative rheumatology book. I thought, wow, now I want to see how the pros do it. This is what they did every day. And I was like, can you not be more creative than this? Like, you went to medical school for 4 years, internal medicine for 3 years, and then 2 years of rheumatology, so you just dedicated 9 years of your life to doing this? I put it on one slide. Your whole life fits on one slide. And for chronic pain, of course, we can always cut their nerves. We looked at this article yesterday. This is brand new, 2012. Sustained rheumatoid arthritis remission is uncommon in clinical practice. We'll probably go back to that in more detail later. But punchline from this article is, under optimal medical therapy by board-certified rheumatologists in some of the best medical centers in the U.S., the best they can achieve is about 10% success over a 2-year period of time. Right? I could do better than that. Well, I'd like to think I can do better than that in like 1 or 2 visits. And I think most of my patients would tend to agree. So what you've got here in these 3 bullet points is actually an excerpt directly from my consent form.